Hello CTSNet friends, welcome to another Beat podcast where we bring you all the latest news, and what a week it's been. Not one but two massive international conferences. We've got ISMICS and the ESTS both kicking off either side of the pond. That's not all we've got for you. We've got some fantastic articles. The ISHLT have produced a massive tome that you have to know about if you're in LVADs. There's a big New England Journal study on MitraClip that you really need to know about. And we've got some great videos. We've got a viral video on lemur harvest. We've also got two fabulous webinars. So do not go away. This is going to be a great addition. So we've got not one but two international conferences. What a week. So ISMICS is kicked off in Boston, and it was really interesting to hear that on May the 20th, 1923, 100 years and 10 days ago, there was a first in Boston. That first was a 35-year-old guy called Elliot Carr Cutler. He performed the first transventricular mitral commissurotomy on a 12-year-old girl. So the modern age of heart surgery began 100 years ago in Boston, exactly where ISMICS is. She survived after that and did really, really well, succumbing only 4 years later due to pneumococcal disease. But it was really lovely to hear that story at ISMICS. The president, Vino Tarani, gave a fantastic presidential lecture. It was full of humility. It was brilliant. The actual title was The Transition from Arrogance to Humility. He told us, don't be scared to say I was wrong or my idea is good, but yours is better. It's really wonderful to hear our top leaders coming down to earth, listening to us and learning from their experience. That was not all. There were some brilliant presentations. For me, Vinay Badwar's robotic aortic valve replacement was fantastic. The Subramanian Award was won by Rick Fischel. And another favourite of mine was Dr. Bulky, who showed us an inexpensive and easy way to set up robotic cardiac simulators. So much there. And the really good news is that CTSNet has paired up with ISMICS to bring you some of the best content of that conference. So look out for it on CTSNet over the coming weeks. That was not all. The ESTS has just kicked off in Milan. This is a very special year for the ESTS. This is 30 years since this amazing organisation was kicked off. And in fact, I'm recording this on Sunday. Just an hour ago on stage, the founding fathers were brought up to a standing ovation. And that was really, really wonderful to see. There's so much going on. Today we had our postgrad symposium and a Masters Cup fighting it out across Europe. And there's going to be a fantastic, really interesting sort of series of talks going on. I think this year might be the start of multi-platform robotics. We've got Medtronic Hugo here. We've got Versius from Cambridge Medical Robotics here. And of course, we've got Intuitive with the SP. So there's a lot kicking off in robotics in thoracic surgery. I'm really looking forward to seeing the presentations on all of these platforms. This week we've chosen three really fantastic news items, and there's nothing bigger than the 2023 International Society for Heart, Lung and Transplantation Guidelines for Mechanical Circulatory Report. This is actually a 10-year update, but oh my God, we have advanced in 10 years. It's crazy to think the differences that have gone on. So Dia Said from Leipzig Heart Center was first author. David Fellman and David D'Alessandro were amazing key authors, but there were over 30 co-authors to this massive tome. In fact, it was so big that they had to break it down into 9 different task forces. So you've got a whole chapter on selection for durable mechanical circulatory support. Of note, that is the up-to-date term. DMCS, durable mechanical circulatory support, should maybe supplant other terms you may have heard. We've got a whole task force on optimizing the patient and modifiable risk factors. We've got intraoperative and post-operative management. We've got an inpatient management of these patients outpatient management. We've got VADs in congenital heart disease, a whole chapter on that. Evaluation for recovery. Only 2% of people end up having their VAD taken out, but there is a whole chapter on this. BiVAD devices and total heart, artificial hearts, which is a whole new big area, and quality metrics. So it really is an incredible piece of work, and it probably took 10 years to create. I had a really good look into it, into this brilliant sort of tome, and most significantly to me, the big changes are the big change from HeartMate 2 to HeartMate 3, and really it's been transformational. HeartMate 2 has really gone out of practice. Also, Medtronic discontinuing the HVAD has been a very significant event, and also really big in America has been the redefinition of the categories for the approval of LVADs by Medicare and Medicaid, replacing traditional bridge to transplant and destination therapy, really opening up the world of VADs. There's some really interesting information on the fabulous INTERMACS database. This is a database of 163 hospitals, all implanting VADs, and they showed that actually, according to North American data, there have been more than 25,000 people that have had mechanical circulatory devices, and 18,000 of them are continuous flow. The other interesting thing that jumped out to me is, although the indication has always been bridge to transplant, only half of those on the database with durable mechanical circulatory support actually ever ended up being listed, not have a transplant, not even listed for a transplant. So while we've been using this indication, actually for 50% of patients, there's really no intention. They never got to transplantation. And interestingly, they talk about this, saying, well, maybe a VAD can be a bridge to consideration of transplant, because maybe you'll get a bit better, maybe you'll be healthier, and that might evolve in the future. The other really fabulous thing about the INTERMACS guideline is that database is that the 1-year survival has got to 83% now, and the median survival is 5 years. So I remember the historical times when median survival was 50% with a VAD, and we were all cheering if they made 2 years. And now half of people are lasting 5 years, with people with the worst heart failure, on inotropes, in hospital, even ventilated. These people are getting out to 5 years. Wonderful work from the whole community involved in mechanical circulatory support. Well done to the ISHLT. So the second paper we've chosen for you is enormous. This is in the New England Journal of Medicine, and I think every cardiac surgeon involved in mitral surgery needs to read this, because this is the 5-year follow-up of transcatheter repair for secondary mitral regurgitation, also called the COAPT trial. Now, this trial, as you might expect, is showing stunning findings. It's showing great findings. It's showing a clinically significant difference in hospitalization at 2 years. So the control group, which is fully medically managed people, 67% of people were hospitalized, and it was just 35% in those having a MitraClip. The death was 46% in the controls and 29% in the MitraClips. So this is a New England Journal of Medicine showing big data, big differences between MitraClip and medical treatment. So there's a few alarm bells though that certainly jumped out to me as a surgeon. Firstly, fully sponsored by Abbott. Secondly, the MITRA FR study, which was in a pretty similar group of patients done in France, had quite different results. They were actually clinically not significant. And there's a few thoughts about why this has happened, but I'm not sure sort of what the differences were, other than it was a study sponsored by industry. So the study, what was it? I better mention. It's best medical support for somebody with severe mitral regurgitation or a MitraClip. So interestingly, in one of their papers, it demonstrates that a MitraClip is $35,000. which I thought was interesting. It was a randomized study, of course, and it was randomized 302 patients to MitraClip versus 312 in controls, and I gave you the results. Now, the average age was 72, which, you know, that's interesting. And the other interesting thing, if you go all the way to the appendix and have a look, is that that actually they had a score of the number of people that were surgically not suitable, and 188 of the patients in this trial were not in a high surgical risk category. So 188 of those patients could have just had an operation. So I think, for me, it shows that we've now got a big New England Journal of Medicine study, and that's great. But one other thing is, in the control group, 21% of people ended up having a MitraClip as well, which was slightly strange. Very high crossover. So we've now got a study that does show MitraClip is better than medical therapy. So we're going to have a load of cardiologists running around saying, let's do MitraClips first. Which I think is quite dangerous. And I think as a community, we really have to circle around those brave surgeons that are proposing a study of MitraClip versus surgical best mitral valve repair with our top techniques, minimally invasive, brilliant repairs. We've got to go head to head. We can't see studies showing MitraClip versus medical therapy. We've got to see studies of MitraClip versus surgery, and they need to be NIHR sponsored or sponsored by objective agencies. Anyway, that's my thoughts. I hope that's not too controversial, and do let me know what you think. Post something in the notes below, or let me know what you think at jdunning@ctsnet.org. The third thing that we have selected for you is a great article by Freiburg in Germany, by Matthias Sieper's group, who's editor-in-chief of the European Journal, and Thomas Berger and Dr. Krybich, and it's a really good study looking at frozen elephant trunk versus frozen elephant trunk with an aortic root replacement. I mean, frozen elephant trunk is a big enough operation, but you know, it's a big deal to add a root replacement to these as well. And this study asked the question of, is that big deal dangerous? Is it worth it? Is it worth the extra time? Or can you do it in a high volume center? And they answered it very conclusively. So they looked at 303 patients undergoing arch replacement with frozen elephant trunk over nearly a 10-year period at their institution. And then they pulled out 50 patients that also had an aortic root replacement. Their findings were that it did have a longer bypass time, a longer cross clamp time. Of course it does, maybe half an hour or so, but actually it did not affect post-operative outcomes. So the mortality was not different for these people, and there was no different overall survival. So really good work from Matthias Sieper and his group in Freiburg, basically showing that if it needs to be done, do it. Do the root replacement, don't compromise, and just go for it.
Submissions are now open for CTSNet's annual Innovation Video Competition. The competition rewards surgeons at the cutting edge of cardiothoracic surgery with a $1,000 cash prize, a prominent feature on CTSNet, and an exclusive interview with the judges. Submit your videos showcasing creative solutions, novel surgical approaches, and technological advances in CT surgery by August 31st, 2023 for a chance to win. For more information, visit ctsnet.org/innovation video competition.
Those were our news items that we did, and we've also got 3 videos for you. Now, we've had a video go virtually viral. This was by Stephen Spindle, and it was from the Oshner Clinic Foundation because it was something simple. It was mammary artery harvest, hints and tips, pedicled, skeletonized, and it was just wonderful. It was only 4 minutes long. You can watch it on your phone, and I think it's a banger. Really, really good. So take a look, show your residents, pass it around, and it was lovely. Really, really nicely done. Great technique, super simple. And I would suggest, if you look at this and you like it, post your best internal mammary harvest technique. We want to see yours. We'd like to get a bit of a compendium of 3 or 4 or 5 or 6 mammary artery harvest videos, because you probably have a few little nuances and hints and tips yourself. They did some really good ones. How to lengthen a pedicle graft, how to cut the lemur vein, how to take the fat off the bottom of it, how to identify definitely the bifurcation so that you don't miss it and cut it too early. I thought it was really, really nice. And also marking the side of the graph. I never used to do that, but this shows that if you just mark it with a pen, you'll make sure you don't twist it by accident. Great tips, lovely video. The second video we have for you is a collaboration between CTSNet and Getinge. We really like to do these collaborations because industry bring a really professional video. They bring the very best people to the table and we get to learn a lot. The title of this video is Advanced Root Surgery. And they got William Brinkman, who is the moderator from the Baylor Scott and White Hospital in Texas, brought Catherine Harrington from the same institution, and also Emmanuel Lansac and Lawrence Dikashova, and they really gave us an expert view of many aspects of advanced root surgery. I was really pleased to see a fantastic talk on the valve sparing root replacement, the David 5. A lovely set of pictures showing the 1 to 5, also describing meticulously the David 5, also called the SMOD procedure. Really, really nice. We saw videos on the cardio route for biobentals, an aortic valve reimplantation, and a cardio route as an external support for a pulmonary autograft in the Ross procedure. Really brilliant. It's a 1-hour video. Settle down with a cup of tea in the evening, put it on your TV, come to CTSNet and put that on your telly and listen to the experts for an hour. It's really worth an hour of your time. For the thoracic surgeons among you, we've also got a wonderful series, and this series comes from the fantastic International Conference for Sublobar Resections. This one, the 4th International Conference, was held in January, and we've got selected 4 of the very best videos on segmentectomy for you. So Carole Fleury from France showed us how to simulate and then perform one of our most difficult segmentectomies, the S9 and 10. Marion Durant, a total queen of robotic surgery, showed us S6 sleeve segmentectomy, which, you know, that is a rare procedure. Carole Fleury also did combined segmentectomies, and then the absolute pièce de résistance for me was from Masaki Sato, how to deal with S asterisk. Have you heard of S asterisk? Well, I'm putting my hand up. I hadn't heard of it. I'm a thoracic surgeon, have been for 10 years, and I did not appreciate this new segment. So this segment, he reports, is present in up to 30% of our patients. It's just below segment 6. It's present below, on the left and on the right. And what is it? Well, it's if there's an extra artery that isn't in the basal segments and it isn't in the apical segment with an extra bronchus. And he gave a lovely demonstration of this, and then he gave a really good talk all about S asterisk. So I thought that was absolutely wonderful. He also said, you know, it's not a problem. Don't stress about it, chill out, because actually you'll either just take it with your apical segment or you'll take it with your basal segment. So it's just something to look out for when you see aberrant arteries on your 3D recons. Great talk. Check it out now. So that was all our videos and news items. I hope you enjoyed some of those. I hope you see them soon. And just to let you know that as well as the ESTS and ISMICS that are going on this week right now, there is also some really interesting things coming up. The EACTS Lung Volume Reduction webinar is coming up. It's a fully virtual event, so you can watch it from the comfort of your home, and it's on June the 14th. So head over to the EACTS website and register right now. There's an interesting connective tissue disease webinar that's going to be taking place as well. This is just documented in the show notes below, so have a little look at that, and if that is interesting for you. And moving on now from the events onto my honourable mentions, and where's Diego? So where is Diego? So Diego, the world's most famous surgeon, has been in China, but he's actually moved units. He moved to a different unit to go and tour around China, and but that didn't stop him. He was still doing sleeve lobectomies and double sleeve lobectomies in a different unit in China. He's going to spend a few more weeks there before he moves on to another country to spread the word. And finally, honourable mentions. I want to give my honourable mention to Professor Eric Lim. Professor Eric Lim is an absolute rocket of a thoracic surgeon. He's at the Brompton. He took over from Professor Peter Goldstraw, and he's doing such a great job. He's already successfully nailed the Violet trial of randomised open to VAT surgery. He's just set up an amazing Ramon trial, the most innovative study you've ever seen. It's all for people with standardly inoperable cancers, stage 4 in some time, brain mets, renal mets. Can we randomise them to consolidative treatment plus surgery, or just consolidative treatment alone? I think it's really amazing. The other thing he has done is he has set up the world's best regular weekly watch in thoracic surgery. There is nothing better than the Brompton Grand Rounds. I watch it sometimes on a weekend if I can't tune in on Friday at 8 a.m. And for our American colleagues, you just need to catch up on the weekend because that's a little bit early for you guys. But he really is having world leaders in every specialty coming to tell us all about the current innovations in thoracic surgery. So well done to him. I really don't think there is something like this in cardiac surgery yet. I'd love to hear if anybody would like to set it up. And do check out the Brompton Grand Rounds on Eric Lim's website. Well, that's all we've got time for. It's been a packed edition, so do tune in next week and we'll take you through all what's big and exciting in the world of cardiothoracic surgery.